big ocean of blood vessels, ocean of vital structures, and just behind the maxilla and mandible, not very far away. So that is what we need to keep in mind, because these are very, very important things. We'll go through three phases in complications. Complications can start with the first step, selection of your patient. So the first point is psychological. Somebody mentioned briefly about psychological aspect of the patient. I can take a talk on 2 hours on just on the psychological aspects, because your literature gives you enough and more publications on psychological assessment of an orthodontic patient. Neuromuscular disorders, because your surgeries can get messy if the patient has got a pre-existing neuromuscular disorder. 3, multiple deformities and syndromes, if they are coexisting with certain other issues in the body, and that can complicate. And the patient has had multiple treatment for various things, it may be also a challenge. So remember these 4 phases, what we look at. So when you assess a patient, I'm not going to read through all this, this is there for you to read, and it's probably also circulated to you or will be circulated to you as well. So what we do is to assess the patient properly. So that's your first step in assessing the individual as to what the problem is or where the problem is, based on all the parameters that everybody has been talking about. The next important aspect, do not forget you are basically a dental surgeon. Right? And we rely on our teeth for everything. Teeth is your guidance for the entire success of orthodontic surgery. If the teeth are not going to be in good position, your jaw is not going to be in good position. If the teeth have a problem in alignment, your jaw is not going to get aligned. Your teeth are not going to be sitting properly, there will be improper fixation issues. When the fixation issues happen, there will be relapse. So what do you need for that? You need good dentition. So your periodontal condition of the tooth, because while I was going to the basic case, this is more important than the next. Your basic stuff, what you have to look at, is more important than the rest of it. So periodontal state, caries tooth, savable teeth, restorations and occlusion. These articles are latest articles which managed to go through, which is very important. This particular article, I would have quoted this most of the slides. It's exactly pre-operative, intraoperative, post-operative complication in orthodontic surgery, a systematic review. Next, the joints were already mentioned. The temporomandibular joint is the most unique joint of the human body, because both the joints have to move together. Right? No other joint in the human body to move together. Right? For one finger, this one finger alone, I don't have to move all the fingers. Similarly, any other joint. But this is the most unique joint. And that is why it's very complicated, and you have to understand and examine the joint before you think of doing some procedure on the patient. So symptoms, assessment, radiography and pathology. Next comes your radiography. Radiograph should be properly taken. A tilted cephalogram will give you alternately different findings, right? So that is very important. You get your radiographs in correct position. Photographs. Photographs play a very important role. You have softwares which can morph your photographs. You can show what you can do in your software. So a lot of photography plays a very important role. Next comes your model. As a student, do not forget the basics. Making your impressions, preparing your study cards, doing your model analysis like the orthodontic PGs would do. You should know something of it. Not that you're going to do physically the model analysis, not required. But you must know what this model analysis is going to give us. All these things based on the models that we have. This is the conventional articulation of the CAS, where we do a face board transfer. All of you are familiar with what I'm talking? Yes or no? Yes. Okay. We do a face board transfer. We orient the maxilla to the skull base, and then you put the mandible. You have your bite wafers, occlusal bite registered, mounted on an adjustable articulator, which will mimic the nose. Now, even now, most institutions definitely do follow the methodology that I'm talking. We can't bypass this because technology is there. Yes, technology is there. But we need to know this at some point in time, and definitely all of you should have been exposed to what I'm talking. This is mandatory for us to learn. Now, supposing you cannot rely on technology, or somewhere you have forced to do something to plan without technology, then this will come into play. So your planning will be psychologically planning, what is the patient's level of expectation that the patient is having, photocephalometric, dental, and the pre-surgical orthodontics. Yes, we talk about SOFA. All patients do not fit in SOFA. Please don't get carried away by doing a surgery first and ending up with a mess with the occlusion and not knowing how to retrieve back after what we have done. So there are situations where you cannot do an SOFA, you need to do a pre-surgical orthodontics. Can you tell me at least 5 points why you should do pre-surgical orthodontics? You. One point. Any point, 1 point. Why should you do pre-surgical orthodontics? Leveling of what? Decompensation. What do you mean by decompensation? Aligning what? Teeth. Which teeth? Only mandible should be aligned. Maxilla no alignment. You're not coming to the point. Why should you do decomp? Why should you do pre-surgical orthodontics? Or as maxilla avoid. There are 8 points in all textbooks. Give me 5. Curve of speed, good. 1 point is right. Curve of speed, to correct the curve of speed. Before that? Huh? To create space. So you don't do anything with the teeth. You said leveling of teeth. What do you mean by leveling of teeth? Alignment of teeth, crowding, rotation, cross bite. Everything has to be corrected, right? What does decompensation mean? To exaggerate the problem. You're going to do something to exaggerate the problem. The patient should be aware of that. Okay, we'll talk about that in complications a little later. So we do pre-surgical orthodontics for various reasons, and sometimes it is mandatory that we go through the process. So essential, accurate patient reevaluation, correct selection of the surgical procedure, accurate prediction duration, accurate model surgery. Now, when we do a model surgery, what all we look at? The tooth size, occlusal plane, space closure, the root shape. You have to look at the X-rays. What is the shape of the roots? Are they very divergent? The convergence of the roots, or whatever. The entire model based on the dentition we have to look at. Immediate preoperative assessment. Planning, final check. Most important, cessation of growth. Cessation of growth of what? Maxilla? Mandible. When does maxilla stop growth? Average. Is it varying between female and male? Yes. If so, when? 14 to 16. In females, okay? Maxilla, mandible? 18. You're stretching it too far for females. 18. So we'll look at average. 14 to 16 maxilla, 16 to 18 mandible. Right? So that's an average of the growth completion. So you cannot plan an orthodontic procedure. The cessation of growth is not. How do you confirm growth completion? Hand-based X-ray. Next, in the cephalometry, do you confirm? Is there anywhere in the set that you look at? Yeah, what is it? Vertebral column. Very good. What do you look at the vertebral column? Square. Vertebral column is not square. I'll give you 10 minutes time after this. No, I'll ask you during the next session. You will tell me what the vertebral column will do. Okay. Right. Speech assessment, medical state, the pre-existing diseases we have to look at, and then accurate record and consent. Consent is most important. You agree? Everything. In any surgery, consent is important. Anything specific to orthodontic surgery, more important, have to be put down there on paper. Operative area, what all we look for? Anesthesia. We look at the theatre preparation and the surgery, what we need to do. Operative complications is under patient care or anesthesia, maxillary or mandibular, whether it's TMJ, nerve and vascular injuries. Now, coming to maxillary surgery. Dr. Lin kept on saying, sir will tell. I put it all in one slide or 2 slides. These are all the complications that you may encounter. Loss of teeth, aseptic necrosis, vascular compromise. Need for the hyperbaric oxygen, questionable. If teeth goes, can you give prosthesis? Yeah. Patient has to accept. So anterior segmental osteotomy, Lee-Ford 1 osteotomy, you combine a procedure, there is a chance that the anterior segment can get necrosed. In my little experience of orthodontic surgery, I have lost one anterior maxilla. I can boast and say that I lost, but it's not fair to tell that. But I say I've seen that complication. And that complication is not a pleasant complication. It's very difficult to face that patient. You know, day by day, one tooth will get necrosed. And you say, see, no mucosa, a bare white bone, dead bone. You imagine what I'm saying? Like you guys would have probably seen mucormycosis where you see bare bone, or osteomyelitis where you see similar situation. So we found out why it would have happened. Then we found that the kid was nutritiously bad and not taking care, no good oral hygiene. That all I can blame on the patient. Ultimately, surgeon is partially responsible for the necrosis. So we accepted it, we gave prosthesis, patient had to accept it, patient accepted it, we did a good process, all that happened. But what I'm coming to say, it's not that it's a ruled out complication. It can happen. Relapse is one of the things which we cannot control in certain kind of patients. Though we have good advanced fixation techniques, though we do good plating, sophisticated instrumentation, relapse can still happen. So your limitation of movement of the jaws, be it maxilla, mandible, advanced setback, all have their limitations. You can't overdo certain things. You want to do beyond certain things, then you don't do orthodontic surgery. You resort to distraction if required. Okay? But it again varies from surgeon to surgeon. I know a surgeon in the US who can advance 21 millimeter of the entire face forward. 21 millimeter. Doing a Lee-Ford 3 osteotomy. So it's again debatable. The other surgeon will say, no, 21 millimeter I will achieve through distraction. So it's all each one's preference at the end of the day. So whether it is advancement, setback, everywhere there will be relapse. Oronasal fistulas can happen. Septal deviation, easily preventable, particularly when you impact the maxilla. If you don't do your septal trimming, every patient will end up with a septal deviation. You need to create a slot in the bone where that septum will rest at the end of surgery. If you don't create that, definitely there will be a deviation, particularly in impactions. Ala base sin suture, again a controversial thing. Everybody says, do sin suture. How long will that suture remain there? That suture snaps one week inside. Who will know? You will know, I know, nobody will know. Correct? We're not using a radio peg material there. We're using a non-absorbable suture. It can give way. It need not work in all hands. So it is debatable. Nerve damage? Yes, nerve damage in different forms. Stretching, retraction. In maxillary osteotomies, your retractor will be sitting on the nerve. 2000 times we tell people don't keep it on the nerve, it will be kept only on the nerve. Because there's a pleasure in holding the nerve down. You don't realize the consequence of it later. Our retraction causes all these problems. Teeth, yes, we have all discussed about that. Your osteotomy should be maintained 5 mm above the canine. The screw will always eventually rest on the root. Sometimes we lock a few roots in between. The endodontist gets a feast after that. We need to support our colleagues, yes or no? So yeah, some damage can be done by you, no problem. It's all inside this room. Huh? If you want to put me and write an exam, Dr. Vivek, go to it. In the session complication, you can go through the route, then give endodontist work. No. You know, many times, people have fixed a screw, surgery is over, tube doesn't come out. You know, I've heard about these things? No. Very common thing. The tube doesn't come out. You know why? The pyrethroid force of fixation, the screw went into the nasotracheal tube. There was no leak because the screw is still there. The screw is just gone in. So the air leak, if the air leak had happened, the anesthetist would have known. So redo surgery, which means open up again. They found out that the screws engaged the nasotracheal tube. They had to remove the screw, reposition the plate. By then the tube would leak because the tube had to be changed. Many times it has happened. Not happened, then HOD to put one screw in the Again, quote unquote. You have to see such things. The tube doesn't come out after surgery, what do you do? So suspect that. So that's why when we do orthodontic, we always ask 2-3 times, tube is which side, tube is which side, tube is which side. So we make sure on that side when we do the fixation, the retraction in the nasal mucosa is good. We don't go in directly, so that, and you don't use long screws in that particular area, so that it doesn't engage the nasotracheal tube. Today, many surgeons prefer doing a submental intubation. Why? They want the nose not disfigured. Otherwise, the tube will pull the nose like this. Then you want to push the nose down to check the position finally. So people want to do a submental. Very good idea. But unnecessarily you're traumatizing the floor of the mouth. In a trauma patient, if I do, I'm justified. And if an orthodontic patient, if I do, I don't feel good about it. I may damage the duct in between. For no reason, there will be salivary pooling, obstruction of the submandibular duct. You never know. Bleeding. People dread bleeding only the most. Right? So, bleeding, yes, is a big challenge in maxillary surgery. Hypertensive anesthesia is sometimes given. So, be very careful of the vessels. No harm in ligating the greater palatine vessel. You have other blood supply. What is the main blood supply coming if the greater palatines are damaged in the maxilla? Anesthetic pharyngeal, right? So these are there. So we don't go and damage them. So palate does get blood supply. The bleeding is sometimes very generalized. You can't really make out from where it is coming. So it is very important that we have good vision, effective suction, good lighting to check what we are looking at. Never panic. As long as you have not gone beyond the pterygoid plates and gone to the curvature, it's fine. But if you are within the maxilla, you don't have to really worry about the bleed. It should stop. It will stop. Okay. Patience is the key in bleed. Pressure and pack is the key in bleed. And more importantly, patience to wait when you put the pressure and pack. And pack 4-5 years. Again it will bleed. Pack, remove, bleed. Patience. Give that 4 minutes to 6 minutes for a little bit of clot to have happened there, and that will give us the idea of the location or the bleeding. This battery is running out on this. Yeah. So what you have to do is pressure pack and observe where the bleed is coming from. So cleft refors, as rightly mentioned by Dr. Vasant, is extremely challenging, and because it's extremely challenging, because you have 2-piece, 3-piece, and therein sometimes you have a wrong split while we do a cleft osteotomy. If a cleft osteotomy, if a cleft maxilla has been grafted well, enough time has been given, and then you take it up, sometimes these osteotomies work very well. Otherwise, cleft osteotomies are definitely challenging. L4-2 osteotomies can cause nasolacrimal problems, positioning. L4-3 can lead to orbital problems, and also smell issues, and also diplopia, anophthalmos. Sir was speaking about trigeminal cardiac reflex. I'll reserve it later for questions. So these are some of the challenges that we have with highly involved osteotomies. And fixation problems, plenty. You will decide to put a particular plate, but that area, the bone may not be very good. You'll have to resort to some other plate. But at any point in time, 4 plates is what we require in the maxilla. Earlier days, as the previous speaker mentioned, we used to only do transosseous wiring. Or we used to do splinting. Make an occlusal splint, put that splint into the maxilla, do what is called per-alveolar wiring. What is that? Have you heard of this? No. How can you not hear about it? In fracture mandibular maxilla, you have heard of circummandibular wiring? The corresponding thing that is done to the maxilla is called per-alveolar wiring. Now go back and read. Okay? That is important for edentulous mandible fractures, or also for the mixed dentition fractures. Sometimes you do per-alveolar wiring also. So it is important that now that we have the advancement in the field of fixation, we are happy to do plane size screws. Can fail. So this is something to show your osteotomy cuts where it has to be limited so that we don't do harm to the vessels behind. So what is the maximum depth that you go with your lateral chisel? It is got your marking there. Huh? 25 fixed. 25. 25 stop. Beyond that, don't touch. Depends on the maxilla, right? Each maxilla can be different, so it has to have a range. Septum, how much can you go? Is there a difference in sound when you tap? What is that sound described as? Crackpot sound. When will the crackpot sound be heard? If there is no what? Or there is no crack? What will happen? What happened? So average is there. See, always whenever we say a number inside anything that we talk, give an average. It can vary. 25 is fine. Some people can have it at 25. But everything is 25, 30, 33 is the maximum they say in books. But yeah, we know roughly when we have to go, how far we have to go. The fortunate thing, the lateral chisel is a guarded chisel. Right? Only one side is sharp. So the guarded side will always protect the vessel. The vessel is very close to the lateral. The greater pylon is extremely close to the lateral. So you can go to a particular. In fact, some people don't go fully. They actually go down, press the maxilla a little bit down, visualize directly, and then go in completely. It's also much better. Okay. So sometimes after all this difficulty, you end up with an open bite. You messed up somewhere. So when you do this kind of thing, what will you do? Minimal things, micro problems can be corrected with elastic. But if it's an open bite of 5 to 7 millimeter, you can't pull it with elastic. You will only put 4 plates there. I'll have to literally hang on to the maxilla to pull it down. It will not come out. So we have to go back. You have to go. The most common thing that can happen in a messed up maxilla is an anterior open bite. Why? So maxilla always goes posterior. Remember that. Okay? So the most common complication that will happen in the maxilla is a anterior. Always maxilla tends to go posterior and backward. Why? Angulation. Which angulation? No. No. Whose muscle is there? Which muscle is there? Medial pterygoid, they are slightly detached. Pterygoid plate is detached. Soft palate. Yes. Why in a fracture also the maxilla goes backward and downward? Soft palate muscles. So they are responsible for pulling the muscle, mandible, maxilla backward. So this kind of situation you will have to operate again. Can you see a problem in this patient? She has undergone a Leeford 1 osteotomy. The center picture, can you point out Leeford 1 impaction? Huh? Deviation of mesoderm. Can you see that? Simple thing. So even if you do a good surgery, you can end up with this if you don't adhere to problem. What is this access osteotomy? For completion's sake, I am talking this, not mentioned by others. So in the maxilla and the mandible, we can do what's called access osteotomy. I have a head and neck surgeon or a neurosurgeon or a ENT surgeon who has to access a deep tumor. So we can do an osteotomy for them. This can also go wrong. When you fix back, it has to fix back originally because patient has no problem with the teeth, with either the maxilla or the mandible. So pre-op, before you make the osteotomy, you have to fix your plate. And then remove the plate. So you have the marking done already. Why I am saying people go end up doing the osteotomy, they struggle to fix the maxilla or mandible. So this is very important. There also you get a complication. You disturb the occlusion in the system. So pre-operatively you have to do your plate fixation and then do the osteotomy. How much? 5 minutes. I just got into complication. I have yet to reach. We have hardly there, man. Okay, I'll speed up. Mandibular surgery, you get condylus sag, improper plating, rotation of the fragments, inaccurate cut, soft tissue, muscle tension, supraomyotomy is to be done. Again, the same relapse, inadequate fixation, non-union. So here we go into the osteotomies, as mentioned by Dr. Ellen, modified sagittal splits, vertical subsequent body, and so on. Sagittal split, you know, the most common complication will be nerve issue. Unfavorable split is not very common, and please don't assume that it is to be common and be seen every day. No, please. Disaster it is. You had one, you will know what it is. Now, what we have to do is impacted teeth, risk for split, as rightly discussed, you have to go through the tooth. We always think of getting the impacted tooth out before 6 months. Invariably doesn't happen. Either the postgraduate or orthodontics messed up or the surgery postgraduates messed it up. Don't smile. Okay, so what happens? So we are forced sometimes to go and do it. We come out successful most of the times. When it goes successful, we are also happy. But it may not be always. So ideally 6 months before it has to get out. Now, relapse is very, very common because if you don't release the muscles well, so what we ideally do when you are supposed to go and finish the osteotomy, you have split the mandible, you run your finger. Finger is the best instrument in that situation. Run it both on the buccal side fully, right down posterior. Run it down full inferior border. Release a little bit of the muscle there. That's all it is. You don't need any instrumentation for this. And to get your the distal fragment moving freely. Go in between the split. Go behind, free it. Just the finger. That's all it's for. And you make sure that the nerve lies onto the body. If the nerve in with more comes a little bit on this side, carefully dissect. Neuropraxia is extremely common. You can't escape without a slight nerve paresthesia in a sagittal split. Very rare, unless totally the nerve is fully in the body. Depends if you've made such meticulous planning where your buccal cut should be. I'm not getting into the details of the other osteotomies for want of time. Genioplasty can be a most tricky osteotomy. In my entire career, I have just seen one case of a genioplasty not uniting. 8 years later or 6 years later, we had to open up because the chin was advanced, but there was no bone. And the patient came 6 years later complaining of pain. We found that there was no bone. So we had to go and re-osteotomize and fix the chin. I've never seen one. The entire career now I've seen one. So like that, you could end up with strange situations as well. So don't think genioplasty very easy, we'll do every day. No, we can't. There also challenges are there. Now again, this is access osteotomy for the mandible. So preoperatively you fix the plate and then go ahead. Back splits, both in maxilla and mandible you can get. Maxilla it can, because it's very thin in the anterior wall. The spreader should be used as a spreader. Right? The spreader cannot do osteotomy. That's where failures happen. You put it in the maxilla and crush, the spreader will go to the eye. Because all the entire bone will go. You lose the bone where you want to fix it. Osteotomy ideally should be with finger. The down fracture should be with finger. Which means you should have completed your cut. If I do this, the bone should come. The spreader is to move it, make it free. Right? Don't imagine the switch spreader, Ooh, switch spreader is called a spreader. It will not do osteotomy. So that is where problems come in both mandible and maxilla. Bad splits come because of that. You have to do your osteotomy well. Right? That will only facilitate release. So buccal plate osteotomies can be all fixed with screws. If you are very confident, you can proceed with the sag still. That is, you fix all the buccal plates together. The ramus fractures horizontally sometimes. You fix that also. And then proceed with your sag fixing, no problem. But you need to be really confident of what you're doing. Otherwise, you'll have to defer totally. Many times, earlier days, people put a patient in IMF for 6 weeks and then look at it later for the sagittal split. So these are all the typical areas where those fractures can happen. Buccal plates, the lingual plates, everything can get fractured. Right. The next thing is, and we can end up with an open bite as well. I'd like to show this particular case. You've seen burr breakage very commonly, right? Can you see this arrow mark here? Can you see this? This was a case about 20 years ago I operated. We had done plate fixation and we broke a burr. 7 years later, the patient complained of pain. And you see the loss of bone there? So a foreign body, sometimes we leave a drill bit inside. So this can lead to it. It's published in the International Journal of Maxillofacial Surgery. And we had to remove this piece of bone completely, sequestrated bone. So these are all very rare complications that you could encounter. So during the treatment, you look at lab issues, intraoperative and post-surgical challenges, orthodontics if it's not bad, lab errors. Largely all that have been overcome with digital planning. You heard at length Dr. John speaking today. We have wonderful facilities today. Your imaging is good, the 3D CT is good. Based on the specifications that is required for the planning software, you have to work towards it. You can work out anything. Sky is the limit, right? And most important is you must have the rapport with the person who is planning, who is working on it. It's just not, I send one CT scan to Dr. John or some other company and I say, do one planning for me, no one doesn't work. There are cases where we sat down for 1 hour and discussed and say, this is what I want. He say, no, this is what is good like this. So that is how that rapport comes. And that is very important for digital planning. It does not come just like that, okay? So airway challenges, bleeding, swelling, infection, analgesia, IMF, how much? All patients should have elastics. Otherwise it's a failure. Don't think you have fixed the best. Guiding elastics will have to be there post-operative. Minimum period 3 weeks. Minimum period. Okay? Then genioplasty plus minus. Avoid open bite. Adequate retention is important. TMJ function to be assessed. Nerve injuries to be managed accordingly. Right? It takes time. Reassurance is the word. But never trap the nerve when you fix it. If that nerve has to be relieved, it has to be relieved. And that is your job. Ophthalmic blindness, yes, rarely blindness have been reported following Leeford 1. It's something which cannot be acceptable, but then yeah, it's a complication. But if you tell a patient that you may become blind, no patient will undergo orthodontic surgery. Correct? But at the back of the mind, it's a complication. Nasolacrimal duct, yes. Vascular compromise, can you see this necrosis of the anterior maxilla? This is how it will look. Condylar resorption has been seen. Veilopharyngeal incompetency, as rightly said, in cleft patients where you advance the maxilla too much. Non-vitality of teeth if the osteotomies are done very close to the apices of the teeth. Dental occlusal disturbances, condylar sac, different types of condylar sac. Preventively, you can fix a plate so that you make sure your position of the condyle can be the same post-operatively and check. Delayed or no bony union reported in about 2.6% of the cases. Can you see this video? This maxilla is completely mobile. Can you see that? Maxilla is like a floating maxilla. There has been no union in this maxilla. Okay? So this is another rare complication. Relapse, of course, is variable. Relapse need not happen every time. But so each patient may vary. Muscle tone will vary. Neuromuscular balance will vary. So all that has to be kept in mind. Hardware problems sometimes. Growth disturbances. Make sure that the growth is complete and you don't interfere with the growth. Even I'm almost done. During treatment, so pre-operatively, clinical, psychological, all these things have to be. Anyway, I'm only going to talk after this also, no? So it's okay. So you have The pre-operative, I'm just putting a summary of all these things. Pre-operatively, clinical, psychological, medical, posture considerations, communication, proper record, growth studies, pre-surgical laboratory workup, all this keep in mind as your checklist. Peri-operative, around the surgery, keep these things as your checklist. Post-operatively, local issues will all be there like this. Pain, swelling, airway issues, maybe. Local speech changes, relapse, TMJ problems, hardware problems. General, psychological. Patient can tell after the surgery, I want to go back to my original. What can you do? There are many patients who have done this. Impossible. Impossible. I've set back maxilla, bring back the maxilla to first position. This is where psychological is. This is the most important part if you ask me. Failure in operating surgery is because patient is not satisfied after the surgery. And that is because you have not assessed the patient what they want. Never convince a patient for orthodontic surgery in your life. Patient should ask for it. This is my philosophy. Right? I can see very tempting. Somebody, the jaw is like this, appointment is so good, I can put it like this. I can suggest. No force. There are people, surgeons who have lost patients by convincing a patient to orthodontic surgery, dying on the table. Not because of orthodontic surgery. Can die. So what do you do in that situation? Patient is not even there. So as a lesson, just keep this in mind. You remember this somewhere sometime when you talk. Orthodontic surgery or aesthetics is something which somebody has to ask for. Doctor, I have a problem in my jaw. Does it look good on me? What can you do? He's my cup of tea. I'm happy. Right? Then I work for it. Okay, these are all rare things. Like DVT, vascular problems, pulmonary embolism. If you're going to keep it. Today, we don't keep our patients more than 1-2 days max. In fact, some cases that we do outside is daycare surgery. I operate in the morning, patient is home in the evening, even if it is by job. Okay. Poor results due to incorrect diagnosis. All these things. You can put listing whatever it is. These are all causes of failure in orthodontic surgery. Final thoughts. Medico-legal complications can arise from poor communication, poor planning, inappropriate consent, poor record. Fortunately, we are all operating in India. There's not much of medico-legal problem. But don't think that people don't have medico-legal. Many surgeons have cases against them. But we get them. We justify, we have done this, we have told this. Even if you have not done, you do some backdoor job, consent written, somebody will write, somebody signs, all that you do. No? Patient, you not going to sign, fair faculty. Yes or no? School, how many people would have signed report card? Honestly, tell me, school, the report card is not shown to your parent. How many of you have signed it? See, very nicely, man. School, man, not now. No, you don't do. You're a doctor. No, you don't do. Only 1% is honest. I don't know how many people use my signature in college. Not that. You not used to? Sure. No operation, no complication. As I started off by saying, you have not done, you have not seen. You have to do something to see. If you have never seen it, you have not done enough. If it can happen, it will to somebody somewhere. Yes, any complication. My patient deserves something better than this. So I don't need to give a complication to my patient. I need to keep him happy at the end of the day. These are some excellent articles. Thanks to my colleague in my department. Given me some good articles which is of use to all of you. I'm sure it is coming to yours, you don't have to take a picture. This is on digital planning. This is on comparison of various approaches. Maxilla-first approach. Current updates and perspectives 2026. Perioperative care in orthodontic surgery. And this is the last of all, what's called enhanced recovery after orthodontic surgery, the new concept 2025, ERAS components. Pre-operative, intraoperative, what you should do. Post-operative, what you should do. This is another article which you should pick up and read this. Thanks for your patience.